Welcome everyone to this month's webinar, Building Your Parkinson's Healthcare Team. My name is Donna Greening and I'm a Programs and Services Coordinator at Parkinson Canada. Before we begin, there are a few items I want to go over. From coast to coast, we acknowledge the ancestral and unceded territories of Inuit, Métis, and First Nations peoples. We've enabled closed captioning for the benefit of attendees who may be hearing impaired. You can turn on or off closed captioning on your own screen by clicking on the CC Live Transcript button and then clicking on Show Subtitle or Hide Subtitle. Please note that this feature uses auto transcription, so there might be some spelling errors along the way. Before we start, we're going to share a video message from our President and CEO, Dr. Karen Lee.
Over 100,000 Canadians live with Parkinson's. We have one of the highest rates in the world. My name is Karen Lee. I'm the CEO of Parkinson Canada. My late grandfather lived with Parkinson's disease, and I know very well the importance of family and how they have to come together to support one another, but most importantly, the person living with Parkinson's. That is why I am dedicated and committed to ensuring Parkinson Canada continues to empower those living with Parkinson's. Each year, our programs and services reach over 10,000 people. We are a community. We are here not only for the person living with Parkinson's, but their family, friends, and their care network to ensure we all continue to thrive. Our advocacy efforts are focused on raising the voices of people affected by Parkinson's. Our Parkinson Advisory Council is made up of people affected by Parkinson's from across the country. They bring a diverse background and experience, but most importantly, they provide me and the organization with advice on topics that are important to them and their community. As a scientist, I know the importance of investing in bold and novel ideas that lead to breakthrough discoveries. At the same time, bringing researchers, clinicians, and people living with Parkinson's to collaborate to push the needle in our understanding of Parkinson's disease. We invest in the next generation of researchers and clinicians to ensure that we continuously understand the Parkinson's disease and also the care management of people affected by Parkinson's. When I'm in the community, I want people to know that Parkinson Canada is with them at every step of their journey with Parkinson's disease. People often ask, when is the right time to connect with Parkinson Canada? Is it when they have their first diagnosis? Is it when their symptoms get worse? Or is it when they need more information and resources? The answer is now. Researchers and clinicians are working tirelessly to find a cure. Meanwhile, every single day, 25 more Canadians are diagnosed with Parkinson's. Our goal is to empower people affected by Parkinson's to live well now.
Now let's get started. Today, we'll hear from 4 healthcare professionals who work with Parkinson's patients and/or their care partners about how the services they provide can improve the quality of life of those affected by Parkinson's. Haseel Bhatt is a clinical researcher and a physiotherapist who is passionate about advancing knowledge and care for people living with Parkinson's. Haseel is the physiotherapy lead and research associate of the Integrated Movement Disorders Program in Toronto. He has lecturer status appointment at the University of Toronto and is a member of the Parkinson's Foundation Physical Therapy faculty program. He is involved in several advocacy initiatives and committees, including the Toronto Western Hospital's Patient Advisory Board. Sarah Awde is a registered speech-language pathologist with over 17 years of experience working with adults with every manner of communication and swallowing impairment. She is certified in both LSVT Loud and Speak Out, the 2 most evidence-based speech therapy approaches for Parkinson's disease. She's also the creator of Get Loud, Stay Loud, an online speech exercise program where individuals with Parkinson's can tune in to daily guided speech and voice exercise classes. Andrea Khalid is a registered psychotherapist with a private practice in Ottawa. Before her passion for clinical work, she worked in neuropsychology and assessment, as well as clinical research, where her interest in neurodegenerative disorders began. She is currently completing her PhD in counseling and psychotherapy, and her research is focused on Parkinson's disease care partners. Yu-Yan Poon is a clinical nurse at Toronto Western Hospital's Movement Disorders Clinic. After obtaining her nursing degree from McGill University, she went on to receive a postgraduate diploma in neuroscience. She's been working with patients who require advanced therapies for 20 years. After working in an intensive care unit in the UK, she joined the Movement Disorders Clinic in Toronto. While working in her dual role as a clinical research coordinator to help find a cure for movement disorders, her time as a clinic nurse is spent providing education on disease management and counseling patients and their families. First, we'll hear from Haseel Bhatt. Welcome, Haseel.
Thank you, Donna. I'm just going to share now. Just want to make sure that I can see my screen and you can hear me okay. Excellent. So yes, I'm going to speak to the role of physiotherapy when you are thinking about building out your Parkinson's healthcare team. And I wanted to start with this figure on this left-hand side that really represents all the possibilities of what that healthcare team could look like. And the green bubble here represents that of the role of the physiotherapist. So as a physiotherapist, we are registered healthcare providers that specialize in the area of movement and physical rehabilitation. And each of these small little gray dots represents us working together with your wider healthcare team to meet your individual needs. And in fact, we were working with a gentleman the other day who described the healthcare team as an accordion that could expand or contract and could change and shift shape depending on the needs at that point in his life. And I thought that was a really wonderful analogy. So what's our role as the physiotherapist? Well, it's to prevent, treat, and rehabilitate the symptoms associated with Parkinson's disease, with an overarching aim to restore and maximize movement, function, and allow you to participate in the things that you love to do. So the biggest question I always get is saying, okay, Haseel, I want to add a physiotherapist as a part of my clinical team. What can I expect? So the first thing we're going to get you to do is come in and we would do a clinical assessment. And we'll have a conversation so I can get a bit of a clinical picture of what that looks like for you. So I'll ask about motor symptoms and non-motor symptoms. So things like your rigidity and tightness or the slowness or bradykinesia that might be affecting your movement. If you have any issues with balance or instability, how that's affecting maybe your walking, your balance, and if there's falls in your history. Physios are really good at treating pain. We would also want to know levels of activity, so where you're starting from, as well as any other impairments or health concerns that really allow us to consider before we begin going on forming a treatment program for you. Okay. So then the next thing we would then get you to do based on that clinical history is do more of a focused exam. And by no means is this an exhaustive list, but gives you a sense of what that could look like. So we might get you up, look at your posture, have you walking. I might challenge your balance, and then more formally assess different areas. So your range of motion, your strength, coordination, as well as endurance. So we'll also want to get you to move and do a secondary task, which we call dual tasking, to see how your brain is able to manage two things at once. And then if you experience specific things like freezing of gait that we sometimes see in Parkinson's disease, we explore what those triggers are more formally. So it's with this question period and this conversation we both have, and then this focused exam, we can then start building out a treatment plan specifically focusing on the goals that you'd like to work towards while maximizing function and independence. So what could that framework look like? So as a physical therapist, I can pull from many areas, supports, and one of those modalities is exercise. So we've heard a lot about this, and exercise probably has the greatest amount of evidence in terms of the interventions for physiotherapy. And we might get you based on your assessment, look at getting you engaged in more aerobic exercise or strength training and balance training, as well as some flexibilities training. Or it could be more non-structured, so just getting you up and moving based on your activity level. So Nordic or brisk walking, things around the house, gardening, housework, as well as recreational activities. So whereas exercise may be planned, structured, and repetitive, some physical activity can be unstructured, but allow us to challenge different movement systems. And then movement retraining is a big one. So as we all know, Parkinson's likes to make things very small and slower. So as a physio, you can use strategies to make movements a lot bigger and faster, and that might influence how you move with your arms, getting up out of a chair, and even your walking. So task-oriented training. So if you're having difficulties, let's say the rigidity or stiffness makes it really difficult to turn over in bed, we can give you specific strategies of how to be more efficient in that movement. Can help with outfitting any mobility aids if that's a concern, as well as movement strategies. Like, for example, if you're experiencing freezing of gait, some of the things that we can practice to get you out of that freeze a little bit quicker. So we can pull from many modalities, but really it's shaped through the clinical assessment and the conversation we initially have. And the last thing I want to highlight is just the evidence, right? So year over year, there's been an increased evidence supporting the role of physiotherapy in overall Parkinson's well-being and Parkinson's care. And this figure on the left-hand side represents all the published studies that have looked at the effectiveness of physical therapy when we're treating Parkinson's disease. And over the years, the narrative of how effective that's been and what it helps has really changed. So in 2004, so up until this point, they took all the clinical studies looking at physical therapy, and they said, all right, let's look at the evidence. And what they found was, well, there's insufficient evidence to either support or refute the effectiveness of physiotherapy in Parkinson's. Fast forward 8 more years, there's more studies published, of course, as you can see in the graph. And then they took all the data again, reevaluated, and found actually there are benefits for physiotherapy, and most of these outcomes over the short term, so up to 3 months, we can see these improvements. Fast forward another, I think, 5 years. Okay, so this would be off the chart now. There's now emerging evidence suggesting that physiotherapy interventions can have positive effects that persist up to 3 to 12 months in some areas, mainly around gait and balance after treatment completion. So we're still learning about the positive effects it can have and driving that influence, driving that quality of life. Okay, so I hope that gives you a little bit of a sense of how physiotherapy can help you and support you in your overall well-being. So I want to thank you for your time, and I will hand it over back to Donna. Thanks.
Thank you so much, Haseel. We will now move on to hear from Sarah.
Okay, just going to share my screen here. And just, can everyone see that okay? And everyone can hear me okay? Good, okay. So the speech pathologist, speech-language pathologist, or speech therapist role in Parkinson's disease is really a dual role. We manage both the communication as well as the swallowing impairments. Now, the communication one is obvious. The reason that swallowing fell under our area of expertise and treatment is that it often involves the same anatomy, physiology, cranial nerves. So when it comes to communication, we can assist with any impairment affecting the voice, any speech impairment, language and cognition, and facial expression, because we know that facial masking is one of the hallmarks of Parkinson's. When it comes to swallowing, we help with management of saliva, the actual chewing, preparation, manipulation, transfer of food to the back of the mouth, the actual swallow itself. And of course, one of our main goals in treating swallowing impairment is to minimize the risk of aspiration. And aspiration is when any food or liquid or medication goes down the wrong way, down the wrong pipe, so to speak. which can, under certain circumstances, lead to something called an aspiration type pneumonia. So we definitely want to minimize aspiration as much as possible. So when we talk about quality of life in Parkinson's, talking and eating rate extremely high in activities that vastly improve our quality of life. So when either or both of these functions become impaired, it can lead to anxiety, depression, wanting to withdraw from social situations, which can really be devastating from a psychosocial, emotional perspective. So just to review very quickly, what are some of the most common communication impairments that can occur? Less clear or articulated speech, difficulty with speech fluency or pacing, quiet voice or not strong enough projected voice is probably our #1 complaint that we get. There can actually be changes to voice quality, so harsh, hoarse, or breathy sounding voice. Difficulty initiating speech. We know that that's a hallmark of Parkinson's, is just trouble getting things going. And of course, as I mentioned, reduced facial expression, which is referred to as facial masking, or hypomimia is the medical term for that. So before I jump into kind of explaining what are the Parkinson's specific approaches or therapies that we use in speech, it's important to understand why this is happening. So the lack of dopamine results in something called a faulty feedback loop. And this is when you make certain movements, maybe it's a voice movement, an arm swing, a length of stride, and your brain can give you false information and tell you that you're making big voice, big movement, big articulation, big facial expression, when in fact, you're making a smaller movement. Parkinson's is the disease of low amplitude. The problem is your body doesn't tell you that you're making a small movement, so you don't compensate. You don't, oh, I need to speak louder, or I need to articulate more clearly. And so there's this sensory perceptual mismatch that occurs. And so the voice gets quieter, the articulation movement gets smaller, the swallowing function reduces. So it's really important to understand why it's happening so that you can really get behind the Parkinson's specific therapies that exist, that are available. So the two main Parkinson's specific direct treatment programs are LSVT Loud and Speak Out. So both of these involve a month of intense one-on-one treatment with the end goal of producing a louder voice and clearer speech. So I'll just very briefly talk about each one. LSVT Loud has been around the longest. It has the most research behind it. And it's typically 4 days a week for a month. So 16 sessions of intense one-on-one therapy with homework every single day. And the focus of that is to think loud. So to overcome that faulty feedback loop, to recognize that your speech is too quiet and that you have to be a little louder to compensate. The second one is Speak Out, which uses the concept of speaking with intent. So using very deliberate, purposeful, intentional speech in order to produce a louder, clearer voice. So there are also some simple voice and speech exercise home programs that you can do, as not everyone has the coverage or funds for a private one-on-one therapy. So you can use these either as a preventative measure to kind of slow the decline of communication and swallowing function. I think my favorite expression that I've heard is an ounce of prevention is worth a pound of cure. So starting earlier and really slowing the decline. Or you can use them as a maintenance program following direct speech treatment. This is where my Get Loud, Stay Loud program comes in, which is that daily online tune in and follow along Parkinson's specific voice and speech exercise classes. So I have the direct links to all of these programs, which will be sent out to you following the webinar. So don't worry about if you don't remember what they're called. So what is our, before I get to that, just the caveat that I'll mention With any direct treatment program, the key to long-term success is in the maintenance phase. So many people participate in direct treatment. They make amazing gains in the month, and then they're instructed following the program to do their home program exercises, which are only about 15 minutes, to maintain those voice and speech gains that they've made. And this is where many people with Parkinson's tend to fall off, as it can be very difficult to self-motivate to do the exercises on a regular basis. Dopamine, as we know, is one of our get up and go neurotransmitters. It's what keeps us motivated to do all the things we need to do. So we can already be behind the 8 ball in that dopamine deficiency in self-motivating to do those things to live our best life with Parkinson's. So I think this really underscores what I think is the point of today's webinar, and that making sure that you're diligent about building your healthcare team beyond your GP or your movement disorder specialist, so that these individuals can work together to ensure a more holistic approach. Speech and voice exercises are fabulous. They're beneficial, but if you're experiencing anxiety and depression and you lack the motivation, you're not going to be able to do them regularly. Another example is physio and occupational treatment are essential. But if your swallowing issues have led to a nutritional deficit that affect your strength and stamina, then again, you're not going to be able to fully participate. So just as a summary, our goal as speech-language pathologists working with Parkinson's is to improve your competence, your confidence, and your independence in your ability within your communication and your swallowing function to improve your quality of life. And just as a sum up, that really brings it back to the importance of building an interdisciplinary team, because as Haseel said, we are all connected. It's one big grid, and we all have to work together to maximize your function and that quality of life.
Thank you so much, Sarah. We are now going to move on to hear from Andrea.
Thank you, Donna. I'm really happy to be here and be part of this webinar. I think it's very important, so I appreciate the opportunity. With over 100,000 Canadians currently living with Parkinson's disease and thousands of new diagnoses annually, Parkinson's disease is indeed impacting a large portion of our population. It's also suggested that over 40% of those living with Parkinson's disease are being cared for primarily by their significant others. Therefore, an even larger population is being affected by Parkinson's disease as a whole. Within the last decade or so, research has really explored how care partners are coping with the demands and caring for somebody with Parkinson's disease. And they have also identified some of the challenges that we are now dealing with from a clinical perspective. So what we are aware of is that as caregiver stress, as it starts out, there is immediate stress, some burden associated with the caring role that care partners have. And as caregiver stress doubles, it doubles when we're caring for somebody with neurological disorders. And it is exacerbated by caring for somebody who is experiencing cognitive impairment or behavioral changes. And so what we are aware of as well from this clinical perspective is that there is a large percentage of people living with Parkinson's disease who do develop dementia. So this is an important piece that we need to keep in touch with when working with care partners, because we know as the disease progresses, the care burden increases as well. So as part of the care partner role, they actually help to support the individual by performing a number of physical activities. So physical, social, and emotional tasks, including assisting with personal care activities, such as bathing, feeding, and administering medications. There is also an aspect of providing social and emotional support to their loved one, as these supports tend to diminish as the disease progresses. So in terms of a psychotherapy approach, what are the ways in which psychotherapy can play a role in the quality of life of care partners? So it is really important as a clinician to work from this approach in asking and encouraging social supports. So what we tend to notice in the research is that social supports are one of the biggest impacts. They have a large impact on how somebody is coping. So from a clinical perspective, it's really important that clinicians tend to ask and encourage all about the care partner's support system and see how that can play a role in helping with the coping. Encouraging self-care practices is one of the biggest pieces as well, as those tend to be the #1 things that tend to leave or to decrease as the care demands increase for the person living with Parkinson's disease. What the research does suggest in terms of clinical interventions is very much this aspect of cognitive behavioral therapy. So oftentimes, this is what clinicians will use to help address some of the symptoms that care partners are coping with. So we work with the way that our thoughts, emotions, and behaviors all kind of go together, and we work on ways of changing our thoughts and approaches to improve our behaviors associated with the difficult emotions or unhealthy coping mechanisms. Another thing that is really important to consider is, as the research has demonstrated, many people who are caring for their loved one with Parkinson's disease do tend to notice a shift in the relationship. So oftentimes what we do here is that a lot of the complaints, a lot of the appointments are really taken over by the person living with Parkinson's disease, because that is the root of what is happening. However, there tends to be a decline in the care partner quality of life, and that's not always being tended to. So it's very important from a clinical perspective to check in. So that's one of the things that I'd like to talk about in terms of how can we work with this, and what are the things that are going to be important to use as a healthcare team. And that would be often checking in with the care partner as well, ensuring that they are coping okay, and asking if there are any additional resources that are needed for them. So this is very much an approach that is starting to be well introduced into a clinical practice. So I very much appreciate just this time to be part of this, this healthcare team, as I think that it's going to be very important moving forward, and especially as we're noticing some of the depressive symptoms and anxiety symptoms that are coming out in care partners. And because of the increase in wanting to keep people living at home for as long as possible before having to move into a long-term care facility, it's very important that we pay attention to the care partner role and how they are coping through this time. So I really appreciate this, Donna. Thank you.
Thank you so much, Andrea. We are now going to move on and hear from Yu-Yan.
So first of all, thank you, Donna, for the lovely introduction. And I'm a nurse at Toronto Western Hospital. I've been here for a little over 20 years. Over the years, I learned a lot from my patients. I usually see myself as a person which is the bridge between the physician and the patient. And most of the Parkinson's disease patient and their care partner come to see their physician about every 6 months or once a year. But what happened during that year or that 6 months? For example, the doctor prescribed medication, you're supposed to take it 3 times a day. And at the very beginning, 3 times a day may be adequate, but people might have questions like, what do you mean by 3 times a day? What is the best time to take this medication? And what if it is increased to 4 times a day? Again, what is the best time to take this medication? And how is medication interfere with the stuff that the person is eating, for example, diet? As nurses, I usually tell my patient to describe the day. What time do they wake up? What time do they take their medication? What is their meal time? And I go through step by step, like every what is your general day looks like, so we can help the patient plan out their medication regimen to a way that it fits their lifestyle and their dietary requirement. And of course, most of our patients take more than one kind of Parkinson's medication. Shall they take them at the same time or shall we take them separately? And what if the person requires medication for their high blood pressure or they're taking some kind of supplement? How is that interfering with their Parkinson's medicine? I mean, going to see your pharmacist, that is one really good resource. They see this is talking about how to review our healthcare team. If you're not sure about your medication, go speak to your pharmacist, or I can reach out to your pharmacist for you as a nurse. Also, we can talk about your symptoms. Lots of family doctor in the community is very much familiar with the Parkinson's symptoms, but there are things that is not as evident. For example, patients develop difficulty speaking. What is it related to? Is it because they have pre-existing condition that can cause them having trouble speaking? Do they need to see a speech-language pathologist? Person started having drooling, and their next appointment not to see their doctor is until another 6 months. What can you do at home to manage these symptoms until it's time for you to see your doctor? And also, the time that the person usually see their doctor is a very brief time. The doctor will have recorded a note. What I usually do very often is in between visits, the patient call, I'll look into the medical record, and the doctor might say, hey, every 6 months, after every 3 months, if you don't notice any benefit, the patient should increase the medication to every 4 hours instead of taking it every 6 hours. So those are the information that kind of help related to the patient rather than you waiting and suffering for another 6 months before you see your neurologist or specialist again. The other thing is building your healthcare team. As like all these specialists, when is it a good time to do a referral? As nurses, we, at least the nurses in Ontario, we can point you to the right direction. We can make a referral to the physiotherapist or the occupational therapist or social worker in the community. So you will have a visit for home safety assessment, to be visited by the occupational therapist to help you manage your day-to-day activities. The other thing is I spend lots of time providing education. And because I spend lots of time on the phone speaking to the patient, I don't see them very often in clinic. And it's very important for us to speak the same language when you go see your doctor. For example, you're only seeing the doctor for 15 minutes. And very often we hear the care partner say, oh, he's in his best behavior. That's not what he looks like when he's at home, which is very true. And as a care partner, as a patient, you should being able to speak the same language as a doctor is very important. Using the word shaking to us as a specialist or as a movement disordered person, there is many different kinds of shaking. So we need to help educate our patient and their care partner to describe those symptoms so the doctor know where to target when you come down for your next appointment. Or just simply help them, like, why don't you write down these questions, document them all, we can help you put it in your medical record, so hopefully your physician will be able to address those information for you. And the other thing is, there are lots of symptoms that may or may not relate to Parkinson's disease. For example, the person had trouble walking. And if the person called me on the phone, I have trouble walking, usually I go over what are the potential reasons of not able to walk. If it is because it's dizziness, and there are many reasons why the person can be experiencing dizziness. Shall you go to see the family doctor? Or shall we give you an early appointment because you need to see your neurologist earlier? Or if you have pre-existing heart condition, shall we review your medication with cardiologist? So all these little things, practical things that I talked that people have challenged with day to day as nurses, I would like to be able to give them advice rather than waiting for their next appointment with their doctor, which is usually 6 months to a year later. And as a nurse, I would like to say that I know what are the resources, exercise group that is available in the community, and direct our patient to do those exercises. And I'm on the same page with Haseel and Sarah. And every time they call, I would say, hey, did you do the exercise? Every time a patient comes in, Parkinson's Society has a, Parkinson's Canada had an exercise book. Have you read it yet? Well, you know what? I can't help you get better if you don't do your exercise. So that's one of the things that I do, encourage them, make sure that they fit their therapy into their lifestyle. And that's all I have to say today. Thank you.
Great. Yu-Yan, it sounds like your role is something akin to a guide, teaching patients and their families how to navigate the healthcare system. I know you mentioned OT, PT, and social workers. What other kind of referrals to specialists can you make for a patient who might be experiencing new or changing symptoms?
As nurses, I cannot directly refer anybody. But if I discuss that with a physician, usually I sometimes even refer them to their urologist, if that is because there are urologists that we are familiar with. And we use those physicians on a regular basis who are familiar with the disease. So these are the knowledge that we have, but we will talk to the doctor or we'll discuss it with their family doctor. We think this is something that you need and maybe they can help referring them to somebody that is closer to home that is familiar with the disease.
Okay. Well, Sarah, so Yu-Yan's talking about patients who have changing symptoms, and we know that a fair number of people with Parkinson's start to experience drooling and sometimes swallowing difficulties. Other than the throat swallowing mechanism, what are some of the other possible contributing factors to swallowing difficulties?
So it's important to remember that there are 3 distinct phases of the swallow, and issues can occur in any or all of them with Parkinson's. So there's the mouth or the oral phase of the swallow where there can be difficulty with controlling or manipulating food, liquid, medication in the mouth. There can also be difficulty moving things from the front of the mouth to the back of the mouth, pocketing food or medication. And then there's the throat or pharyngeal phase of the swallow. And people with Parkinson's can have difficulty triggering a timely or a strong swallow. If the swallow is delayed or weak, it can increase the risk of food or liquid going down the wrong pipe, so to speak, which is aspiration, and thus increasing the risk of aspiration type pneumonia. And then there's the third phase, which is the food tube or the esophageal phase. And there can be issues with motility or moving the food through to the stomach in a timely manner. So besides those 3 distinct phases of the swallow, another culprit that many people don't think about is dry mouth. So in Parkinson's, this is usually attributable to either a medication side effect. Lots of medications cause dry mouth, and or B, being suboptimally hydrated, which could be related again to a swallowing difficulty with fluids. And we don't think of something like water being difficult to swallow, but if you think about it, it's liquid, it doesn't hold its shape, and it runs the fastest in the mouth. So if you're not getting optimal hydration because of difficulty swallowing, you can get dry mouth, which is problematic because it's our saliva that helps to mechanically lubricate our food and then chemically break it down so that it's easier to swallow. So I think the key takeaway, if you're experiencing any difficulty with swallowing, seek out an assessment with a speech pathologist through your primary care physician. You can also request a home visit through, now this keeps changing. They used to call it CCAC, LIN, Home Care Services, whatever they call it in your province, or you can contact a private speech pathologist for an assessment.
It sounds like it's a lot of stress for people who are experiencing those speech and swallowing difficulties. Once those challenges are addressed and they're getting better, what kind of other what are the changes that you see in the patients once they're swallowing better and their speech is better?
So after we've been involved and we've helped to remediate or help with swallowing difficulty, I think the biggest change that we see is just a general reduction in anxiety and stress in general, which of course is globally going to improve their quality of life. As I mentioned in my little segment, eating is such a social event. So many people with swallowing difficulty withdraw from social events that involve eating, which is usually all of them, especially this time of year, as they're self-conscious about their swallowing impairment. So a speech pathologist can not only recommend exercises to improve swallowing function, but we can also provide tips and strategies on optimal positioning, special postures or maneuvers to do when you're swallowing, food texture modifications. So when you have improved swallow function, you're going to have improved nutrition and hydration and medication intake, which means that that individual with Parkinson's can now more fully participate in their physio, occupational therapy, counseling sessions. So it really does have a global impact on quality of life.
That connection between hydration and nutrition and being able to fully engage in those therapies, it's such a really great point. Andrea, if a care partner connects with you regarding their mental health, how could the amount of attention given to physical and emotional self-care negatively impact their own mental health? And how do you address that?
So typically when care partners come in because they're seeking help, because they're noticing some psychological challenges, one of the biggest impacts is usually self-care. So oftentimes it is going to be about addressing those needs, what needs are not being met, because oftentimes care partners are putting all of their attention towards the person that they're caring for and neglecting their own needs. So when it comes to self-care practices, I usually talk about these 4 pillars of health that we need to maintain in order to try to stay as resilient as possible. So that would be eating well, sleeping well, exercise, and social connection. So when we take a look at it from that perspective, it's usually, or oftentimes we can identify some of these needs that are not being met. And so in order to get through whatever it is that somebody might be needing to get through in those moments, it would be to use a strength-based approach to try to figure out or try to tease out which part is not being met and try to figure out ways from a psychology perspective to try to implement some of those needs and try to do so with the time that they have and given the circumstances that they're in as well. Sometimes it has to do with not sleeping very well because they're experiencing anxiety, worrying about their partners, they're not taking care of their nutritional needs. So it's going to be really important to target those pieces when somebody comes in to see exactly what it is that is happening for them.
It's so true that there is that emotional aspect of care partnering, but also there's that physical toll that it takes on care partners as well. Haseel, it's clear that working with a physiotherapist can improve stability and motor symptoms in people living with Parkinson's, but how might you incorporate mental health strategies with patients that you see?
Sure. Yeah, this is a new emerging area of rehabilitation. So there's good evidence now that shows the connection between mental health symptoms and motor symptoms in Parkinson's. Right. So in my world, I see a lot of people experiencing freezing of gait. And the research is now showing that mental health symptoms such as anxiety, which is very common in Parkinson's, can be a common trigger for freezing episodes. Right. So as a physiotherapist working in Toronto, I've learned from some wonderful mental health experts and neuropsychiatrists and our mental health nurse, and I've begun to incorporate strategies. So as Andrea was mentioning, principles of CBT, body relaxation techniques, breathing exercise, and then pairing that with exercises that we do traditionally in physiotherapy to target freezing of gait. And we're seeing some good benefit. We're hoping to formally study this to be able to look at this more deeply, but pairing, sort of having both a mental health strategies and physical strategies and targeting problems together can be really beneficial for the folks.
Mm-hmm. And how do you treat care partners who've got repetitive motion injuries? And how does working with a physiotherapist help equip them to meet the challenges of daily living?
Sure. So what I can say, there's definitely a subset of care partners whose roles are very physically demanding, right? So it's not uncommon. I might be seeing a patient and the care partner is close by and they're complaining, and the two areas are low back pain and shoulder pain. And it's these repetitive movements that they're doing. And when we dig deeper, sometimes it comes down to improper body mechanics or lifting mechanics, where the care partner may be trying to help their loved one get out of a seat or get out of a car, and they're in a position where they're vulnerable to injure themselves. So a lot of the things I do within those sessions is to work with the person living with Parkinson's, but also to train the care partners how to best support their loved one, but to do it safely.
I can definitely see how taking action and finding ways to navigate changes by doing the right kinds of exercise or learning new ways to move can have a huge positive impact on people's physical well-being. Sarah, how can speech therapy improve the mental health of both people with Parkinson's and the people in their families?
So when you maximize an individual's competency and confidence when they're communicating, we can greatly enhance their independence and quality of their interaction with their physio, the occupational therapist, physician, mental health care professional, et cetera. So as a result, they may rely less on family or caregivers to relay health information, and they can participate more fully in their treatment plans. And I think maintaining this level of independence with their healthcare team will also have a really positive impact on their mental health, as depression and anxiety are common when people become less capable of being involved in managing their appointments and conversations involving their care.
Yu-Yan, what changes do you see in patients and their families, and how are their clinic visits different after someone has taken part in speech therapy?
I find the patient usually is able to voice their concern and be more as an active role in terms of rather than waiting for somebody to speak to them when they're communicating with their healthcare team. And with speech therapy, again, it's extremely important that they interact with their family and they learn how to find out what's the important things to say, what are the things that come across, and it becomes more enjoyable and better quality of life, and able to enjoy. Like, speech is not just about talking, also eating as well, right? If they're able to enjoy their food eating outside, or able to manage eating a proper meal at home, I think I do see patients who have a better quality of life, and also a bit of weight gain as well. Sometimes it's a little challenging for our patient if they move too much.
Mm-hmm. Well, thanks so much for a great conversation. We're now going to move on to questions that our audience have submitted. This is a question for Andrea. Someone asked, are there any ways I can encourage my family member to seek mental health help?
That is a great question, and I get that question fairly often. It's a very difficult and touchy subject for many people. There are gentle ways of approaching this, and that would almost just be, almost setting some boundaries as well in terms of, it really sounds like you're struggling right now. I wish I could help you. However, I know that there's probably somebody that might be able to help you a little bit more, somebody from, outside of our family. It's very important to kind of be gentle with it. Otherwise, people can tend to be defensive as they feel like they can cope and deal with things on their own. However, there are these gentle approaches where you can sort of utilize it as like, this is sort of a team approach. And we know that these are some of the impacts that Parkinson's disease may have on people and their loved ones and care partners. So we can use it in that sense as well.
Thank you. A question for Haseel. Someone has asked, how can you help someone who has had Parkinson's for 13 years and refuses to exercise? I believe this person is still in denial.
So I can speak more generally about this question. I think we need to first acknowledge that engaging in consistent exercise routine is difficult for many people, whether you have Parkinson's or not. And having a healthcare team can be helpful in tackling this issue. So from the research, what we know and clinical experience is what some of the well-known barriers to exercise is low outcome for expectations. So based on how much they're going to improve their Parkinson's symptoms versus how much they're going to input with the amount of exercise they're doing. That's why I spend a lot of time educating, and that's why I showed that last slide to show that there can be some substantial benefits there. really redefining exercise. I've had many people say, you know, Haseel, for me, going on the treadmill is not the thing, but I love hiking. So just drawing parallels that, you know, you can engage in the same movement activities. And in fact, sometimes hiking allows you to challenge your balance at the same time. So redefining the problem. Isolation is another one. So, you know, people are more likely to engage in a consistent exercise program if they have a partner or a group that they're accountable to. Fear of falling is another one. So having them work out with a physiotherapist in a safe environment. And then maybe, and this is probably more in Andrea's world, is apathy, right? So apathy is a very common symptom where there's low motivation to do these things. So having to tag team with the physiotherapist and the psychotherapist can be really helpful in addressing these things.
Mm-hmm. Andrea, have you got anything to add?
Not too much to add, but from maybe a clinical perspective, it might be important to address, you know, are there depressive symptoms that are, you know, not allowing this person to try to engage in those self-care practices that are going to be beneficial for them?
Okay, thank you. So this question was asked in general, but I'm going to direct it to Sarah. Would any of these therapies work for someone who is also affected by dementia related to Parkinson's?
So if the person has more of a mild to moderate dementia, and I'll speak from a speech perspective, I would say that they most definitely can participate in a direct speech therapy or even a home speech exercise program. The core Parkinson's specific voice and speech exercises are really quite simple and repetitive. Exercises can also be modified to meet that person's ability. If there's more than a mild dementia at play, then there would likely need to be assistance from a family member or a caregiver to provide reminders and prompts about doing the exercises, perhaps even some gentle cueing or modeling during the exercises. If there is a later stage dementia, for example, an advanced Lewy body dementia present, then direct therapy might not be feasible. And at that stage, the burden falls to the family or the caregiver to provide assistance with facilitating and supporting conversational exchanges. And a speech pathologist can provide that education to train the family or the caregiver on how to do that.
Okay, thank you. Do any of the other panelists have anything that they'd like to add about their specialty and dementia? No? Okay. This question is for Yu-Yan. Can and should a person with Parkinson's access therapies such as acupuncture, massage therapy, a dietitian, or naturopath on their own, or should they be prescribed by their GP or neurologist? And a follow-up is, what would the GP or neurologist want or need to know about those treatments?
Oh, for acupuncture and massage therapy, there is no evidence that they are beneficial. However, there's also no evidence saying that is not helpful. I do experience some patients if massage therapy is going to help reduce the tightness in the muscle, which is sometimes Parkinson's disease patient experiences. I do not see a reason why they cannot practice massage therapy. Now, the second question that you were asking is homeotherapy or naturopath. When it comes to homeotherapy and naturopath, again, there's no evidence indicating that some of them are helpful or actually, some of them are actually not beneficial to the patient. I usually ask them if they're taking anything, please bring us the list or what is the ingredient, which I've been doing a lot. Please take a picture of the label and let me know exactly what you're taking. I mean, it might not be harmful to the person, but it might interact with the medication that they're currently taking. So that's our point on having homeotherapy. So, but again, the bottom line is if they are interested in using marijuana, and yes, I usually strongly advise them to see a marijuana specialist. They are existed in the community to get the advice on which type specifically to get, rather than just going to buy on their own. Am I answering all the questions, Donna?
Yeah, absolutely. The next one is for Haseel. I know you've covered a lot of this already, but someone asked, my partner is having freezing gait episodes and falling, and they feel so helpless. What can they do?
I did see a question in the chat that said, what is freezing of gait? And we should have specified that freezing of gait is this idea where sometimes your feet can get feel like they get stuck to the floor, and some people with Parkinson's, living with Parkinson's, experience this symptom. So with that, we're still learning a lot around freezing. What we find in the research and in the clinical practice is there are some strategies that can be very helpful. The two most commonly strategies are around cueing, right? So this idea where your feet become shuffly and then they feel like they're stuck to the floor. So placing lines, visual cues out in front of you allows us to use different parts of the brain to bypass the issue in Parkinson's, which is in the area of the basal ganglia, and to allow to initiate that step, as Sarah was talking about, that feedback loop. And the same thing with auditory cueing. So we'll work with somebody coming into the clinic and see if playing music while walking is helpful, or a metronome. Also treadmill training, if that's appropriate. So having people walk on a treadmill, and then general exercise. So engaging just in a little bit more exercise. Let's say you're not engaging in these specific therapies, but that you have access to a gym or working with a physiotherapist that deem you safe to be on the treadmill or just do general exercise. That has shown also to help with managing these freezing episodes.
Okay, thank you. This is a question for Andrea. Someone asked if it's common for Parkinson's psychologists to not take on patients over the age of 75, as did two that they contacted about an appointment. And if that is common, why would that be so?
So I'm not sure that it's common practice. I think it really depends on the mental health practitioner's specialties and the populations that they may be working with. Typically, populations are broken up into different pieces. So whether it's children, adolescents, young adults, seniors. So it would depend on the person's specialties and comfort in working with a particular population. But I don't think it would be common practice for people to not take somebody in based on the fact that it's with regards to Parkinson's disease.
Okay, thank you. This question is for Yu-Yan. How can a person who might live in a rural area, how can they include different healthcare specialists if they can't get a referral to a larger center?
Lots of the larger center offer remote visits. That's number one that we should look into, and we are more open to seeing patients virtually rather than seeing patient in person. So I would say, even though you might not be able to physically access the center, I would still give it a try to send a referral to those bigger center and see whether you would be able to see the patient virtually. And for physiotherapy, and I think Haseel will agree with that too, there is lots of virtual classes and virtual assessment that can be performed without the person being there in person. And again, the key is not just to see the specialist. The key is the person has to practice the exercise. Seeing the physiotherapist or the occupational therapist or the speech therapist once for a consultation, once a year, is not going to change anything. You really need to do some homework, the person themselves. And there's so many virtual classes online that are free. There's boxing classes. There is National Ballet Canada doing all the different classes online that the person does not need to be there in person. And I think even with physiotherapy, you are given those exercises and the person really needs to do the exercise. So I would say, even if you live in a rural area and you want to send a referral to the larger center and see what option treatments are available, even though you might not be able to be there in person, still give it an opportunity and have to see whether they can do a virtual visit. And I mean, nowadays with the pandemic, even for a patient who comes to our clinic regularly, we offer virtual visit. We see the person once a year in clinic, and then the rest of the time, if we do, we see them virtually. So there are so many possibilities with the technology. I would still say, please go ahead and see what option is available for you at the larger centers.
Thank you. Here's a question for Sarah. Someone has asked, after LSVT, do you recommend all 3 follow-up programs to see which one fits best?
So the 3 programs that I mentioned, the first 2, LSVT Loud and Speak Out, are just different options of direct therapy. So those are the, I'm not going to call them packaged, but they are very research-based, and they're sort of a month intense direct therapy. And you could speak to your speech pathologist or your doctor about which one might be more appropriate for you, but they're just 2 options. And then after that, the key is that home practice. And the program that I created is just a way to help you with that home practice, that home adherence to, you know, the rest of your life when you're going to do it. Because the thing is that those direct treatments are time limited. They're 1 month. So either LSVT Loud or Speak Out, both are fabulous, have lots of research behind them. The key is to just maintain and do the exercises after the direct treatment.
Thank you. So 2 questions came in and they're quite similar. So I'm just going to ask one of them, and it's for Haseel. Is it important to work with a neurophysiotherapist versus a general physiotherapist if you have Parkinson's?
Sure. So I think if you can access a neurophysiotherapist that has experience working with people with living with neurological illness, of course, then they'll feel a bit more comfortable. They might have a little bit more experience. That being said, you know, there are many people who I've met in rural areas that don't have a neurophysiotherapist, but have a very dedicated physiotherapy team out there and willing to learn. And there are multiple resources. And I liaise with many physiotherapists in the community to teach them around that, and then also do a little bit of training. So as long as they have a dedicated physiotherapist that's willing to work with them, and some of the principles around exercise and recognizing what are the things that they have to look out for when creating an exercise program. I think it really comes back to what Yu-Yan said about the work happens outside the clinic, right? So there's really good that if you say how many hours you're with a physio or an OT or PT throughout the week versus how many hours that they need to be doing the exercise on their own, that's where the real impact comes in, and that's where we see the greatest benefit.
Thanks, Haseel. So we've got a few questions that have come in asking about how would a person get an appointment with either you or the people who work in your area of specialty. So if you could each let people know if they need referrals or if they can just self-refer. Maybe Andrea, do you want to go first?
Sure. So for myself, it's just self-referral. People can reach out or just, you know, even Google my name. There's a website if somebody wants to get in touch, or I can refer out to other helping professionals that might be useful for them.
Mm-hmm. And Sarah?
So as far as an initial communication assessment or just a clinical swallowing assessment, again, you can self-refer. You can just contact your local, what are we calling it these days? CCAC, Lynn? It keeps changing. You can, is it the Lynn? You can contact them for a preliminary swallowing assessment, just bedside assessment or preliminary communication assessment. If you require an instrumental assessment, so that's like a modified barium swallow under X-ray, then you do have to have a doctor's referral or a script for that. As far as LSVT Loud or Speak Out, you can just go on the websites. You can search their clinician search in your area to find a practitioner that's registered or certified in those areas. The only caveat I would say, and I've included this on my handout, is that for the LSVT Loud program, you may be required for clearance from an ear, nose, and throat doctor or an otolaryngologist to make sure that there isn't any other issue at play that's causing the voicing issue. But that's only for LSVT Loud. As far as my program, it's just speech exercise. It's not direct therapy, so anyone can do that.
Okay, thank you. Haseel?
Yeah, I think Yu-Yan and I are in the same boat in that she's just down the street and we work together and collaborate together. So we're in the hospital. We only at this point in time are accepting referrals from where Yu-Yan is working at the MDC at Toronto Western Hospital, but we're building out some more programs that hopes to be coming on board in the future. So The short answer is if you're a part of the Toronto Western Hospital Movement Disorders Clinic, you can definitely ask for a referral to see us here at Toronto Rehabilitation Center. Okay.
Thanks. Yu-Yan, did you have anything you wanted to add to what Haseel just said?
So yes, like Haseel said, I am part of the Movement Disorder Center at the Toronto Western Hospital. We do need a referral from the physicians. It does not need to be a neurologist. It could be just a general practitioner or even a nurse practitioner. And please don't get discouraged about the waiting time to be a new patient. Yes, it is long. And we try our best to expedite the referral. And we do have lots of patients waiting to be seen in the clinic. But for me, it is worth it. And I know lots of patients. We understand that it is very long waiting time, but we are constantly expanding. We're constantly looking for new therapy. So waiting to see us, I think is worth it.
Thanks. Quick question for Sarah. How can a person prevent dry mouth overnight?
So my best tip is to get a really good humidifier. So put a humidifier in your room over the winter months. The air is exceptionally dry. So it may be dry air that's contributing to it. At your bedside, keep a glass of water or even some, there's actually oral sprays that you can get like Biotine that you can just, if you wake up really dry, couple of squirts in the mouth. Donna, I have a really good dry mouth handout that if it's okay with you, I'll send to you after.
Absolutely.
And anyone that wants it, I've got it all laid out, all the tips and tricks on how to combat the dry mouth.
Great. That would be wonderful. Well, we've definitely run out of time for questions today. Thank you so much to Haseel, Sarah, Andrea, and Yu-Yan for providing us with a lot to think about in terms of planning for our own circles of care. In about a week or two, we'll send you an email with a link to a recording of this webinar and any resources that were mentioned here today. Next month's webinar is on disability and care partner benefits and tax credits, and it's taking place on Wednesday, January 18th. Watch your email inboxes for more details and a registration link. On behalf of everyone at Parkinson Canada, I'd like to thank you for joining us, and I hope you enjoy the rest of your day. See you in the new year.